Everybody's ready? Okay. All right, let's start. Good day and welcome to this Waterloo Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research at the University of Waterloo. Thank you for joining us today for our final seminar for the spring term. This is a seminar in the series entitled The Many Facets and Faces in Health Informatics. I'd like to welcome our web viewers and Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation. We welcome all questions from the audience here in the room as well as those coming in via the web and via teleconferencing. And we just ask that we get a mic to you if you have a question that you want to ask. A very warm welcome to our guest speaker, Dr. Danny Sands, Senior Medical Informatics Director at Cisco Systems and Assistant Clinical Professor of Medicine at the Harvard Medical School. Dominic Covey will introduce Danny in just a few minutes. I'd like to acknowledge our seminar series sponsors, Borden Ladner Gervais, McKesson, and Healthcare Information Management and Communications Canada. We could not host these seminars without their support, and we're very grateful for their support. In addition, I'd like to acknowledge the support of Cisco for this seminar. Just to let you know, we'll be taking a break over the summer and will not hold seminars in July and August. Our next seminar in the series will be on Wednesday, September the 24th. We will go back to the seminar series theme in September, so we look forward to seeing you again in September. This seminar series looks at the many different facets of health informatics and some of the key people involved in these areas. So we've had people talk on all sorts of topics from personalized medicine and health informatics as a critical support to clinical research and medical imaging. So our agenda today is as follows. Dominic Covey, Founding Director of the Waterloo Institute for Health Informatics Research, will introduce our speaker. Danny will speak for about 45 minutes or so, and then this will be followed by our chance for the audience and everyone viewing the presentation to have a chance to ask a question in a facilitated discussion. So please hold your questions to the end, as I indicated before. Signal if you've got a question that you want to ask, and we'll get a mic to you. Those of you on the web or the video conference, please forward your questions to us, and we'll get them to our speaker as fast as we can. So may I now introduce to you Professor Dominic Covey, who will introduce our speaker.
Thanks, Shirley, very much. I've only known Danny, I guess, for about 5 or 6 years personally, but before that, it's from the literature for a lot longer. And I have to report to you that Danny Sands actually ruined my relationship with my wife, which is why I brought him here today, is to actually torture him. We were at a meeting in Key West, Florida, and Danny and his wife turned out to be fabulous dancers. Ever since that time, I've been unable to live down the fact that I am not a dancer. So this has been very difficult for me. I've been threatened with dancing lessons. I've been threatened with many, many possibilities. And so not only good looks can compete in a marriage, but also the ability to dance. And Danny's the second person we've had here doing lectures that is a big dancer. Jim Anderson was here before, who's very active in that area. And we understand that Steve Lawrence has been taking dance lessons. So I'm really in that group of people who's really out of it all. One thing I noticed about One thing I noticed about Danny was his incredible ability to speak in different meetings. He's an extremely good speaker. He's well known, well liked, really enjoyable person to be with. So I'm very much looking forward to the presentation today, and particularly from someone who's got such a deep relationship with the private sector, and I'm particularly interested in how that's working out. Relatively few people in health informatics are deeply in the private sector, and it's a unique contribution. Danny earned his baccalaureate degree at Brown University, a medical degree at Ohio State University, and a master's degree at the Harvard School of Public Health. He did his residency training at Boston City Hospital and was an informatics fellow at the Beth Israel Deaconess Hospital, where he was for many years. He's an assistant clinical professor of medicine at Harvard Medical School and maintains a primary care practice in which he makes extensive use of health information technology. So we'll hear about that. Today he's going to talk to us about illness in the age of E, how connected technology changes the patient perspective. Danny, welcome.
Thank you, Dominic. Thanks very much. Well, good afternoon, and greetings to our web audience. It's a pleasure to be here in Waterloo, and as I was just sharing with Shirley and Dominic a little while ago, I've always wanted to come here because the very first, can't quite call it a programming language, one of the tools I used in college on a mainframe computer was Waterloo script. And I always wanted to know where Waterloo script really came from. And I find out that it's right here. And in fact, Shirley was one of the people who worked on that project. So it's very exciting to be here. And no, I don't use Waterloo script anymore, but that's okay. So Dominic asked me to start out by talking a little bit about what it is, how I got to where I am today. So I trained in internal medicine at Boston City Hospital, as you heard. When I was at Boston City Hospital, one of the things that struck me was how inefficient so much of what we did in healthcare was. In fact, not only inefficient, but part of the inefficiency comes from searching for information. The fact that we have a disconnected environment and we're trying to connect things all the time, so many times in a manual way, that struck me as a real problem. At Boston City Hospital, back in those days, we had one building in which all of the medical patients, that is non-surgical patients, were housed. And that included 2 intensive care units. For that entire medical service, that entire building of 6 floors, there were 2 computer terminals. 2. Now, the computer terminals ran a very antiquated system that it was very hard to get your information out. People stood there for a long time waiting in line and queuing up to just get your patient's test results. The good news about that was while you stood in line, you heard all the latest gossip, right? But as I was there, I was contemplating on the fact that we've got to be able to do better here. So I vowed that I would try to change things in any way that I could. Following my residency, I trained in medical informatics, or what we called clinical computing, at Beth Israel and Harvard Medical School. And then I stayed on there in that environment at Beth Israel, which then became Beth Israel Deaconess Medical Center. And I was there for almost 14 years. I was part of the faculty, but it was an interesting group because I was part of the faculty and also part of the operational organization, the IT, or Information Systems Organization. So I had responsibilities which were both academic as well as operational. And while there, I participated in the creation of many systems to help clinicians take better care of patients and to help patients take better care of themselves, and systems to bridge the patient to the clinician. In 1998, I co-authored, as a product of some work at the American Medical Informatics Association, I co-authored the first set of guidelines for the use of email in patient care. This came out in January of 1998, and it was quite striking because when it came out, nobody noticed. And that's because we were a little bit ahead of the curve. It never occurred to people, except for a few of us, that this is going to be useful, this is really going to be hot. And sure enough, 9 months later, after these were published, my phone was ringing off the hook. And people are saying, wow, we found these things that you wrote, and everyone's talking about using email in patient care. So that was probably the beginning of my engagement with patients and thinking about how patients can be involved in their health and how we can connect to patients a little bit better. I maintained my practice part-time on the side when I was at Beth Israel, and I did some consulting and speaking outside of the organization. And one of the companies, at one point, one of the companies that I'd been working with asked me if I would come and help them become a healthcare company. And so I did. I became their first chief medical officer, and this was a technology company that had technology that might be useful in healthcare. And indeed it was, as well as the acquisition that they had that helped them to do e-prescribing. So Zix Corporation, I helped them become a healthcare company. And that was very, very exciting. And then I was recruited to this company called Cisco. I said, Cisco? What are you recruiting me for? And they said, well, we want you to be Director of Medical Informatics. And I scratched my head and I said, wait a minute, Cisco? I don't understand. What's that about? Well, it took me a while to understand this, but I'll explain it to you as I explained it to Dominic at lunch. Cisco is a big company. Now we have 67,000 employees around the world, and it's a really superb company with its heart in the right place. About 8 years ago, Cisco decided that although they had been very good about doing sales and engineering in a very horizontal way, our CEO wanted to really understand individual industries. So they set up a part of the company which was a small part, less than 250 people around the world, to focus really intensely on specific industries. And so I'm part of the healthcare team. And some of the things that we do are we continue to be subject matter experts to understand the industries for which we're responsible. And we do research in that area. We do writing, publications. We do teaching, lecturing. We show Cisco what the needs of the industry are, and we show our customers that we understand your industry. We also form relationships with the executives at our customers around the world. So we're kind of like a global consulting organization. We're very small. So that's kind of what I do at Cisco. This group is called the Internet Business Solutions Group. And Cisco, in addition, has other people who focus on healthcare who do sales, and then we have a more standard consulting model organization. But my job is as a subject matter expert and a consultant, I suppose, within Cisco. But it gives me the opportunity to continue my work with people like Dominic and others around the world and continue to forge these relationships and do exciting projects. I maintain an academic affiliation at Harvard Medical School, and I actually practice still half a day a week in my primary care practice. I have a wonderful practice at Beth Israel Deaconess Medical Center. All right, that's the background. So with that as a backdrop, what I'd like to do is I'd like to share a story with you about a patient of mine. His name is Dave, and Dave has allowed me to discuss him in public, so I'm sharing it with you with his consent, not to divulge his privacy. But and Dave actually is very interested in this as well. We're actually writing a paper together. Dave had been my patient for a while before he moved away. He moved away for a while, and one day I got a message from him. So we have this portal that I helped develop at Beth Israel Deaconess, a patient portal called Patient Site. And it allows other things, we'll get to that later, but it allows doctors and patients to communicate in a secure electronic medium. Although Dave had moved away, one day I got this message from him out of the blue. He said, "Hey Danny, remember me? I'm Dave. I used to be your patient. Would it be okay if I be your patient again because I'm moving back to the area?" I said, "Sure." So that was interesting, right? We rekindled the relationship that way. Dave set up his appointment with me. And then he did something very interesting. He sent me an email, a message. It's a secure message, right? It said, "I'm going to be coming in on whatever date it was, and these are the things I'd like to discuss with you when I come in. My shoulder's bothering me a little bit, been a little depressed, got this, that, and the other thing." So he had a list of items that he wanted to discuss. And then we were able to negotiate the agenda for this visit. Now think about this for a second. How much time do you have when you go see your doctor? 10 minutes? 15 minutes maybe? If you're running a meeting at work, you have an hour maybe, right? And you're going to send out an agenda to people and say, if you have any questions or comments about this, let's work this out. Isn't it ironic that in healthcare we don't do that? And yet we're more time constrained than you are in your organizations. But this is something that I do with my patients and Dave did with me, which was great. This was wonderful because that way his expectations were met and mine were met. Because I have an agenda too, after all. I should parenthetically say that years before this, when Dave was my patient the first time around, when he first started using this website called Patient Site, he sent me a message one day. He said, "This is great. I am having a really fabulous patient/customer experience so far, which is kind of neat, because we don't think about patients as customers very often, do we? It's a certain irony. We're taking care of you, but we don't think of you as the customer. Probably because you're not paying the bill, right? Think of customers as people who pay the bills. We'll get back to that. So Dave came in for his appointment. And one other thing he said, by the way, he said, my shoulder's bothering me, and I know that you're probably going to need to send me to a specialist, and it's going to take a long time to get that appointment. So is it okay if I go ahead and schedule that appointment now, ahead of time? So I said, yeah, that's fine. That's, again, improving the efficiency of the whole system. I said, fine. He can always cancel it. So Dave came into my office, and we went through his numbers and his interim history. We looked at his record, and we have an electronic medical record in our environment, in our practice. It's a record that is useful for every clinician who's taking care of patients. Now, when you go into the doctor's office in a practice in which you don't have an electronic record, the doctor's always shuffling through papers and rarely shares them with you. Even though you're there, this is your record, right? Well, we don't believe that that's the right thing to do. And so what we do is we orient the computer so that both the patient and the doctor can see the computer. So I'm able to share your information with you right there on the screen. We can say, oh, look, that's what happened when you stopped taking your blood pressure medicine. Look what happened to your numbers, right? Those kind of things are very powerful. And to have that experience in the office means a lot to patients. All right, so Dave and I sat down, we looked at his record, we reviewed the things that had been going on, and we went through his things one at a time. Ultimately, I had to prescribe him a medication, and Dave thought it was great because we discussed the medication. He asked me a couple questions that I didn't know the answer to, but right there on the computer, I didn't have to say, gee, I don't know, or make up an answer. Right there on the computer, we looked it up together, and I found the answers. The medication that I ordered on the computer was then checked for safety, both in terms of the dose and conflicts with other medications and problems that Dave had. Then when everything was all set, at the stroke of a button, I transmitted that electronically to his pharmacy. How cool is that? One other thing happened. As I ordered that medication, educational information was printed for Dave about that medication, so he could look at this. And he was right. I didn't know what to do with his shoulder, so I said, go ahead and keep that appointment with the orthopedist. All right, so let's see. We took care of the things in the office there. Dave then saw the orthopedist a couple weeks later. The orthopedist sent me an email saying, Danny, I saw Dave. I think he's got a little rotator cuff disease. I got an x-ray, and the x-ray didn't look too bad on his shoulder. But we saw a mass in his chest. Now, Dave wasn't coming to me coughing or losing weight or anything. But his x-ray of his shoulder, incidentally, we found this mass in his chest. And this was obviously quite shocking to me. And quite shocking to Dave when I talked to Dave about it. Dave and I discussed this, and he was actually able to look at his result on the computer through Patient Site. Again, it's his record. It's you. It's your stuff. You have the right to look at that. So Dave was able to look at this, and we talked about what the next step was. Now, he asked me what this could mean, and I said, I don't know. He was scared, and frankly, I was scared. I mean, my heart sunk when I saw that x-ray. I said, Dave, we're going to have to get a CT scan, a CAT scan, so we can see the whole chest and see what's going on. And we're going to have to talk after we have that test done. So he said, okay, whatever we have to do, let's do it. So we ordered the CT scan, and another few days passed, and we talked again. The CT scan showed that he had 5 tumors in his chest. 5. Now that's just devastating for both me and for Dave. When I told this to Dave, he was obviously quite concerned. Now, we don't know what these are yet, but there are only a couple of things that can look like this. And one of them is cancer. And because there's so many of them, it's probably something that's spread already, a metastatic cancer. There was a small chance this could have been some kind of unusual infection. Now, Dave was a pretty healthy liver. Not his liver, you know what I mean. He lived well, lived healthfully, I should say. He was a little overweight, not a smoker or anything. And I really didn't think that this is going to be a cancer. Perhaps it was just wishful thinking on my part. I didn't want to believe that this guy who I'd known for so many years had a terrible malignancy. Again, it was helpful that Dave was able to see his record online. After this, we talked about what needed to be done, which is that he was going to need to see the specialists necessary to definitively figure out what this was. As I referred him to doctors, he was able to follow along with his test results and see everything online, which, of course, is very useful. Over time, eventually, we figured out that what he had was metastatic renal cell carcinoma, metastatic kidney carcinoma. Now, Dave, understandably, it's his body, Dave wanted to learn about what this was and what it could be. What does this mean? So Dave did a lot of research, and he found out that half the people who have this disease are dead in less than 6 months with this stage of the illness. Quite disturbing. I referred Dave to a doctor, Dave McDermott, who is in our hospital, but he also uses patient site and believes in engaging patients. And he managed Dave's medical therapy at that point. Dave said, well, Danny, what do I do? You know, what should I do in addition to going to the doctor's appointments and so on? And I said, Dave, here's what I'd like you to do. I want you to do everything. I said, you asked me earlier if I should keep singing. He likes to sing. He sings in barbershop quartets. Okay? He said, should I give up the singing? I said, no, keep singing. And he said, should I tell my wife? I said, yes, you have to tell your wife. But she's going to worry. I said, it's okay, you've got to tell your wife. It's really important. You need the support. And I said, remember that thing I told you about cutting down on the ice cream, dieting? Forget about that. Eat everything you want to eat. I also said, Dave, I want you to write. I want you to send me messages through Patient Site as often as you want, even if you may not get an answer or you don't expect an answer. He already knew to send me information about important things, but I just wanted him to write because I thought that was very therapeutic, and studies have shown that to be the case. And then I told him about an online patient support community called ACOR. Has anyone heard of ACOR? It stands for the Association of Cancer Online Resources. ACOR is a website. It's actually hundreds of websites. But it's a website devoted to online patient support communities that are cancer-specific. So going on to ACOR, you can find these communities of people who have your illness, or who have been through your illness before, or who have loved ones with your illness. Dave found a community for people with renal cell carcinoma, really reached out to it, and they provided him tremendous support. As Dave went through this whole process of getting the workup and the diagnosis and the treatment, one day Dave said to me on the phone, he said, Danny, because of what I'm doing here, which, by the way, he was not only on Patient Site, but of course he was on ACOR now, and he also set up a website, by the way, called Caring Bridge, which allowed him to keep his friends and family updated about what was going on with him. Okay? He said, I've now found a community of people, hundreds of people, who I can talk to about my illness, who understand it deeply, intrinsically. And they've all got experiences where when they were diagnosed, they felt isolated, cold, alone, cut off, and unsupported. He said, I don't feel any of those things. He said, I feel like nobody's hiding anything from me. I have access to information. I have this support community. It's a totally different experience. Dave went on and got his treatment. He kept singing as much as he could. I told him to, and he was eating. He ate lots of ice cream. He was happy about that. Fortunately, he did well. He did very well. He responded well to the special therapy that they gave him. And what he learned was that information that people find is not always the most accurate information, or it's not the most current information. And because of the fact that we were able to connect him with medical care that provided him the latest treatments, that 4 to 6 months thing that he read about wasn't accurate, because we can do better than that in some situations. I think the most heartwarming thing that happened to me after this terrible ordeal that both he and I went through was one day, after he had finished his therapy, his hair had grown back, he was gaining weight again. He sent me a message on patient site, and the subject line was, "Now about that shoulder." So that's what happened. And as I said, Dave and I are writing a story about our story. And Dave actually has now started blogging about this. So there's a web blog about this that you can all look at. If you look up e-patient Dave, e-patient Dave, you will see this. So he's very excited about it. He really believes, and if he were here, he would tell you this, that this saved his life. By this, I mean connected information technology. The technology that connected him and his providers to information. The technology that connected him to a community of people who shared his condition. Those technologies were very powerful, and he really feels that he owes his life to them. I want to just explain to you that none of this stuff just happens. To some extent it does. It requires a community of people interested in doing these things. But let's think for a moment about what are the technologies that need to be in place in order to make this happen. And by the way, I don't think this should not be an isolated episode. I think that this should be everybody's experience if they, God forbid, should get stricken with a serious illness. So, let's not start with the patient right now. We'll go back to the patient. Starting at the hospital, part of what made this work was the fact that we had connected information technology in place in my practice and in my hospital. And that allowed me to spend time caring for Dave when he was in the office, or even when he was not in the office. Studies have shown that doctors spend up to a quarter of their time looking for information. That's unacceptable. So by having the tools available to me that connect me to all of his testing, wherever it was done, that allow me to find his test results, to order his CT scan. By the way, I ordered that CT scan when I was out of the office. I didn't need to go in there. In fact, I checked his results when I was out of the office too. I don't need to be in the office. The office is a very inefficient place to get things done if you don't need to be face-to-face. So we have this environment at this hospital and this practice which is very connected. I have tools I have an infrastructure, I have applications that sit on top of that, databases, and tools that allow not just things to happen, but things to happen for me at the point of care. And then we have an environment set up in the office so that this isn't, I don't know if the camera will reach over here, but one way we could have used this technology is as an additional barrier, where I'm standing over here behind the computer, sitting behind the computer, and I have Dave over there. That's a barrier. I don't want that. What I want is an open environment where Dave can share his information. Which brings us to the next piece that we need. You are the patients. If you come into my office and I say you need a blood test, I'm taking a piece of your body. I'm taking your cells. That's assault. Maybe it's for good reason, but it's assault. Now, is it acceptable for me to say to you, I'll let you know if anything's abnormal? Heck no. You have a right to know what's happening to those cells. What's happening with them? What are the results? And if it's for something serious, you really want to know that information. So we believe that this is exactly what needs to happen. We shouldn't wait to know whether or not I'm going to look at the results and whether or not I'm going to have the time to let you know. What we need to do is we need to let you see it as soon as possible, as long as you have access to someone who can help you understand it if necessary. And ideally, we can create a tool, a viewer, if you will, that helps you understand what you're looking at. But you have the right to look at this information. And I believe it's everybody's right. And every lab, every hospital, every practice needs to be able to provide this information to their patients immediately. I mean, heck, you can track a Federal Express package, right? You can track these things all over the place. Why can't you track your specimen? Find out what's happening with that. Right? So that's the next piece of the infrastructure. And then we need a network. We need the network of people and machines that we call the Internet. And we need the World Wide Web, which runs on the Internet, that enables all of us to be active participants. It makes all of this technology accessible to us so that we can reach out not just to our doctors and our labs and our pharmacies, but so we can reach out to other people. It's the human connections that are just very important here. So those are the necessary pieces that we need in order to make this really work. But it is a change of paradigm for us, and by us I mean doctors now, for us to think about sharing information. Or even communicating using email. Oh my God, right? Many doctors believe that all of this technology is something that's being to us. It's for you, the patient, which is fine, but I'm already bedraggled and tired and overworked. You're going to make me do something else that's not going to help me? But one of my lessons from this is that this is something that benefits me as well as you. It enables me to feel more comfortable taking care of you because I have information. I don't have to pretend I know the answer to everything. I know where to find it, and I can help you find it as well. And although this is high technology stuff at some level, it is technology, it really enhances the relationship that I have with you. I feel closer to my patients who use technology like PatientSight than I do to my other patients. Because how often can I see my patients in the office? Not that often. But we can keep in touch using these technologies. And this isn't even high technology. This is low-tech, secure messaging like email communication. I haven't even begun using in my office instant messaging or video conferencing or other things that might draw us closer. The idea is it's much more satisfying to practice medicine if we have a strong relationship. That's what it's all about. It's the relationship. This is why doctors and nurses and other clinicians go into healthcare. It's to take care of that patient. So much has gotten in the way over the years, as any of you who are doctors or patients know. So much has gotten in the way. And I think technology can be a tool that helps dissolve some of those barriers so that we can actually be closer. I can spend less time worrying about information and where to find it and more time being a healer and bringing my wisdom to bear on the situation rather than just regurgitating facts. I can educate you better if you're a partner here. You will have better outcomes if you will participate in your health. If I can say, here's some information. Here's some information on the web. Look at this information. After you've digested this, come on back and let's talk about it and how it applies to you. That's going to be a much better discussion. It's going to lead to much better outcomes than the usual, which is maybe I'll give you a piece of information and maybe I'll spend a couple minutes talking to you. We need to move from an environment of information asymmetry, where the doctor knows or thinks he knows everything and the patient knows nothing, to one of information symmetry, which I think is much more fulfilling. And most patients would feel the same way. What are some of the lessons that we learned from this experience, Dave and I? The first observation that we made is that there's an issue of managing expectations that bears on improving productivity. When Dave was able to negotiate this agenda with me, his expectations at that visit were met. How often have you left the doctor's office and you say, oh, I forgot to ask him this? It happens all the time. And it happens that patients leave the office and I haven't addressed the things I want to address with you. Okay? By negotiating agenda ahead of time, this is very powerful stuff. And we're more productive that way. The next insight is that safety is a safety insight. Dave felt, and it is true, that we have a much safer environment to take care of him. Because I have this tool that knows things that I can't always keep in my mind. It knows all the drug interactions that might be an issue. It knows that this drug is related to that drug which Dave's allergic to. Right? That's very powerful. And the convenience is important as well. Because I was able to send this prescription to the pharmacy, Dave didn't worry about losing it or not getting it filled or anything. He didn't waste time at the pharmacy. Right? And this was very powerful as well. The next issue is that electronic communication is much more efficient for many of the things about which we communicate. Now, electronic communication does not need to be, or should not be used, I should say, for urgent issues. Something that's emergency or that's time sensitive, obviously you don't use electronic communication for that. But when we look at the number of issues that doctors need to ask their patients on a day-to-day basis, a lot of them could be handled asynchronously, without regard to time. And so isn't it more efficient for you to send a message when it's convenient for you, and me to respond when it's convenient for me? Moreover, it allows me to have a conversation with you that persists. So, because it's self-documenting, right? You can look at this email thread. So if you forget what I said to you, which, by the way, after the patient leaves the doctor's office, I'm sure this doesn't happen to you, but after the patient leaves the doctor's office or hangs up the phone, people remember less than half of what the doctor said. And after you've left, that's it. You can't go back and find out, right? It's lost. It just dissipates into the ether. But now we have something where you can look at this, you can look at my notes and refer back to it later, perhaps even discussing it with your loved ones. And rather than shooting from my hip and making up an answer to you that may not be entirely correct, I can take a little bit of time to read it and respond to it. And we found that patients, and Dave tells me this all the time, they understand that it's not just a freebie that they can just send emails whenever they want. Patients tend to be very considerate about the use of my time. And I think it's very powerful that way. So it really improves efficiency. It allows me and you to control your life better, rather than playing telephone tag, right? They telephone tag all the time, or trying to set up an appointment, and you're going to wait 3 months for an appointment with me sometimes, and it might not work with your schedule, and so on. The next insight that we had is one of cost effectiveness. Dave said that 90% of the time, information came from 3 sources. His healthcare providers, who all had access to the same information, the same database of information, the connected healthcare team. his community of close people that he allowed to look at his record online, people who he knew who may be nurses or other people who might be able to have some insight. And then the third was his broader community of people in the ACOR network, other cancer patients and survivors. When we look at those three things, it's actually all pretty efficient. It's very cost effective. So that was the next insight. The next insight is trust. Dave said something interesting. He said, you know, just because I have access to all this information doesn't mean I'm an expert in healthcare. Dave said, I'm not going to hang up my shingle just because I have this information, right? What Dave understands is that he has access to raw information. He still trusts his healthcare providers, his doctors and his nurses, to really help interpret that information. So there's a certain mutual trust there. I have to be able to trust that he's not going to abuse the information and do something stupid, and he's got to be able to trust that I'm going to help him understand that information. Next insight is timeliness. He really believes, and I think this is true, that having access to information and being able to push things along on a schedule that's urgent to him but may not be as urgent to me really saved his life. And final insight is connectedness. That having an environment in which everybody and everything is connected is really important. Really important. It really makes the difference between a patient having a bad experience in healthcare and bad outcomes and a patient who's having good outcomes and a good experience. The healthcare system that we have needs to change. It needs to change to understand these issues of connectedness and engagement with the patient. It is my sincere hope that all of us who are doctors and represent hospitals and practices will change, will connect systems within them, connect people, including patients, to what we're doing. By doing this, we will improve patient experience, we will improve doctor and other clinician experience, and we will improve the outcomes that we produce as a healthcare system. Thank you.
So we have a chance now to ask questions and or make comments. So I'll first open it up, and I see your hands. I'll try to we'll get you a microphone. I have another one here, so I can get you one. Maybe you want to start? Go ahead, Don.
Not trying to be flip, I assume Dave is real.
Dave is real, and I'm sure he would have loved to be here, but we'll make that happen sometime.
Right.
Go to ePatient Dave, you'll find him.
You described a nirvana, so to speak, in terms of your interaction with Dave, the email, the integration with the pharmacy, the integration with other specialists, et cetera, et cetera. How wide is that? I mean, for instance, you could take a small geographic area. The Boston area, in many ways, is not that big, and you could do probably a fair amount of integration. How widespread is it? Who did it? Who made it happen, et cetera?
So the question was, how much integration is there in the broader community outside of, say, the greater Boston area? Well, I will say that the medical system integration, that is all the applications that we use, patient sites and the radiology systems and lab systems, electronic medical records, all of those are in one single network of care within the New England area, sort of the Boston area. The pharmacy system is somewhat separate, but it is a connection from one network to the other. There's a network across the United States called SureScripts, which allows us to electronically prescribe prescriptions and prescribe drugs and have them sent to the pharmacy. And so this is widely used among in organizations in which there is e-prescribing. That's part of e-prescribing. But further answer your question, no, we don't have enough of this kind of networking, if you will, these kind of connections. There aren't enough organizations that are doing those sorts of things. There aren't enough communities that are connected in that way. In the U.S., as in Canada, there are a number of efforts in place to try to increase that connectedness. But some are doing well and some are doing not so well. Some are going slowly and some are going more quickly. So the answer is, it ain't perfect. We're not there yet. But in some areas, we're really getting close to there. I still wouldn't call it nirvana. That's a little bit too strong a word, but we are getting there. Certainly this experience, compared to the experience of 5 years ago, and the experience in most of the country and most of the North America, is night and day. So it's a relative nirvana, let's put it that way. In the back.
I guess my question is sort of similar in a way, except it's about the ethos of the people. I think that you touched us all, in a sense, as patients. But if you were giving this presentation to 200 docs, I'm assuming that their response might be different. I mean, there are issues around email and litigation and having trails, and there's privacy stuff. So in addition to setting up the hardware and the connectivity, you need the ethos of the physicians to go along with the views that you have. And I'm sort of curious about how you go about training it. I guess it's got to change. I'm assuming it's also not quite at nirvana yet in Boston. It's probably not like that here. And so I wonder how you change the attitudes in order to accept the change that, or is it passive, I suppose? One thing is to provide the machinery, to provide the network, and hopefully they'll just get overwhelmed by the wave, or are they real, is it an active thing? Sorry, I dragged on.
Yeah, so the question has to do, and I'm glad you brought that up, this is not just put it in place and it'll happen. It requires a definite change in people. On the one hand, there's a change in patients, which is that people need to be more actively engaged in their health. And often it takes a serious illness for that to happen. But in general, I think that healthcare needs to become less of a spectator sport, and people need to be more engaged in their own health. But you're absolutely right that we need healthcare providers, doctors, nurses, healthcare organizations, to change the way they think about healthcare. We need to think more about patients as customers. We need to think about customer service. And we need to help physicians understand that this is not something being done just to them for the patients, but it's really empowering to both the patients and the physicians. And that is often a tough sell to a busy, overworked physician who never even makes it home in time for dinner with his wife and kids, or husband and kids. But it is a very important lesson, and it is my goal to try to touch as many physicians as I can and help them understand this.
Getting the reality again, at Beth Israel, for example, there's a system there, so many physicians use it there. How would you estimate or give us an idea of how many of them use it to the degree you use it in patient care? I know a lot use it to get data back and so on, but to what extent have physicians adopted the concept of being connected with their patients through this kind of medium?
It's a very good question, Dominic, about how deep physicians' involvement in this is. And I don't think we've really had an opportunity, or we haven't quite figured out the way to measure that. So in a sense, we want to know is how much have they adopted, internalized this, if you will. Made it not just a tool, but something that they really believe in fundamentally.
They believe in it. They actually use it the way you do. In other words, in dealing with their patients, they share information. Their patients use the portal. They share information. It becomes a primary, sort of like another player with them. There's a third agent there, if you want. To what extent does that happen in actual practice?
I don't know the answer to that, but I'll have to respond with a non-scientific anecdote, which is that when we started letting patients see their records online, it was very off-putting for many of our physicians, particularly our specialists, when a patient would go to see them for the first time and say, well, I looked at my CT scan results, and here's what I want to ask you. Very off-putting. We're not used to this. We even have a law in the U.S. It's called HIPAA, which one of the things it does is it guarantees you the right to see your record. But it doesn't guarantee you the right to see your record in any form at any time you want. You have to go through and get a copy of the paper record and so on. But now what we've done is we've opened things up. So what we've found is that we don't hear about these physicians who are kind of put off by this anymore. And I think that physicians are some of them reluctantly coming along and understanding that this is a new world. And that, I think they sort of go through the Kubler-Ross phases of accepting it, I suppose. But they, some physicians don't want to give up the ghost that they know everything and their patients should know nothing until they tell them. But they're gradually, I think what happens for some of these laggard physicians is that at first they're shocked by this stuff and they're upset about the fact that patients have access to their own records. And then eventually they sort of don't get shocked by that anymore. And then the next step is that they use it to their advantage, which is they say, well, you've looked at this information online, so now let's talk about what this means. It's almost what happens now. I don't know if you buy a car in the United States now, it's very different, probably in Canada too. It's very different than it used to be, because when I go into the dealer now, and I just went through this, they assume you've already done research. They assume you've researched things on the web and that you know exactly what they paid for that vehicle and not what they're going to charge me for it. And so we start negotiations in a whole new way because I'm an educated consumer. And I think physicians are coming to that point as well. But it needs to be cultural. It needs to be an institution that's behind them. On their own, I don't think they would go that direction.
Interesting. So basically the people eventually accept it. Now that's presumably within your health system that you've got, Beth Israel Deaconess. Now, what about other areas? In other words, if you went out to rural Massachusetts or you went to other cities, to what extent has this actually penetrated there? I mean, in Canada, by the way, the rule here is that we own our record as well. But the barrier is enormous. It's not open to you. You have to ask, and sometimes you actually have to press to get record. And I've almost seen no examples of the sharing of screens. Sometimes it's front to back where you have screens on both sides. Very rare still. So there's still this barrier that's up here.
Well, the thing that's been gratifying for me is that I'm seeing an increasing number of institutions that have done similar things to what we did at Beth Israel Deaconess. That is, that they've created a patient portal for both communication and allowing patients to see the record and getting education and doing the kind of convenience transactions. We didn't talk about that, but requesting a prescription or an appointment or referral or so on. An increasing number of institutions are doing this across the United States and increasingly in other countries as well. It is still not common. It is way not common, but it is definitely coming. And there, I can cite for you, I can list for you a number of institutions that have done that. Smaller practices are a problem. Although in the United States, 2/3 of care is provided in small practices. And small practices are not likely to have the resources to have an electronic medical record, let alone have a patient portal. I think that's slowly changing, but it's still going to be an uphill climb. So we see, for electronic medical records, something like 40 or 45% of very large practices use an electronic medical record. But among small practices, it's 10%. And so if we don't have the electronic infrastructure to begin with, then we're certainly not going to have a patient portal.
Just for comparison, the data here is that 22% of physicians in Canada have electronic medical record system, but only half of them actually use it. So we have a much lower level of penetration.
Yes.
Hi, Danny. I have a question, and that is, can you visualize the patient site for me? When I sign on to it, what do I see?
Certainly. Now, first of all, I would say that if any of you want to go to see Patient Site yourself, you can go to patientsite.org and click on the demo button, and you'll go in there as if you're a patient. When you go to Patient Site, you first of all say you're logging in as a doctor or as a provider or a patient. Then once you do, you log into that, and the first thing you see your health homepage. And in the central section, it lists all of your providers. They may be doctors and nurse practitioners and so on, whatever different specialty they're in. And by the way, if you click on them, you'll get information about their practices and so on. Another section, you'll see upcoming appointments that you might have. Another section, you'll see educational links that you have, which may have been things that you chose to be there. For example, let's suppose that you were interested in high blood pressure. We give you collections of links on high blood pressure you can just drop in there. Or you can find your own and put them in there. Or I might have diagnosed you with high blood pressure and I might have sent you a link through Patient Site, and then you can easily put that on your home page. So those are the kinds of things that are in the middle of the home page. And then over on the side, you have the area where you can you can go to your mailbox, or you can do these kind of convenience transactions like request a prescription or an appointment or referral. You can look at your bill, and then there's a part where you can look at your record. And you can look at your when you go to the record section, you can actually choose which record you want to look at. Because all of our connected institutions, all the practices and hospitals and so on, you may have a record in each of those places, and we want to enable you to see everything. So you can choose the place you want to see it from, the type of information, the date range, what have you. When you're looking at your labs, for example, your laboratory tests, you can click on the name of the lab at the top of the column, and it'll open up a window that explains what that lab is all about. And then finally, there's a section of Patient Site that allows you to store your own personal information. So if you want to track your back pain each day over time, or you want to track your blood pressure, your blood sugar, whatever it is, you can track that. You can enter notes and enter other information as well. Does that give you a sense?
Yeah, very good.
Okay. Yes?
I have the advantage of access to a laptop, and there's no fibs here. I've read all about ePatient Dave and patientsite.org. So
thank you. See, it was true. I didn't make it up.
Yeah.
Of course, on the internet, you never know who it really is, right?
Healthcare providers and physicians are the ones who are bearing the upfront cost to transfer all patient records to e-records, yet they are not the ones who benefit financially from doing this. It is the government and insurance carriers that benefit financially, and yet they're not paying for upfront costs. How do we give the physicians incentives to move towards an electronic patient record?
So the question is about financing all of this neat stuff, the electronic medical records, the patient portals, what have you. A study was done by the Center for Information Technology Leadership that showed that when you have a full functioning electronic system in your office, an ambulatory setting, that allows you to order things and so on, about 90% of the benefits accrue to people other than the physician. And yet the physician is fronting the cost for this. Now, when we talk about this, so clearly something's going on. And the reason that that's happening is because you, the patient, are benefiting because you're getting better care, which doesn't directly impact me. And insurance companies or people who are paying for care are benefiting because it may help me prescribe more cost-effective medications. It might help not reorder a test that was already done. So there are a lot of benefits to other people other than me. And in fact, for me, it's going to take me at least as much time to deal with this electronically as it will with the paper world. So how do we deal with that? Well, I think that from that standpoint, one possibility is that health plans, or in this country, the government, needs to help subsidize the cost of these systems because they are achieving improved outcomes and better care. That's one way of doing it. And another way of doing it, which I think is equally important, is that we have got to stop paying for quantity care and instead pay for quality care. Let's think holistically about this. Now, most people don't understand that in healthcare, the more I do, the more I get paid. And unfortunately, that's pretty much true in Canada as it is in the U.S. It's one area where we do have a common problem. So in a sense, if I take worse care of you and you develop a complication and come back and see me, by Jiminy, I get paid again. Yahoo! Now, obviously, we want in the most positive way, we want good things to happen, but how much am I going to pay out of my own pocket to make that happen, make good things happen? So we need to think holistically about healthcare. We need to figure out a way to pay for quality care rather than quantity. We've got to think not only about how do we improve your outcomes, but how about satisfaction? In the U.S., actually, many health plans are now giving physicians a bonus for making patients happy. What a concept. So if I'm doing a good job, we're also getting paid bonuses now for quality measures by some health plans. But the patient satisfaction thing is coming, and it's going to be more prevalent. So that I got to try to make people happy too. So then it becomes in my interest to not only provide good quality care, but do things that are going to make you happier, make your experience better as a patient. So these are very hard questions, and I don't mean to be glib about the answers. This requires a huge cultural shift in the way we finance these activities. And we've got to make sure, by the way, that we can't just buy technology aimlessly. We need to have good technology, we need to have good implementations of the technology, and we need to make sure the people are using it appropriately and are receptive to it. Tough problems, all of them. And we need more people who understand this intrinsically. And that's one of the things that Dominic and I were talking about earlier is the need to train health informatics professionals. We don't have the capacity to train the number of health informatics professionals that are needed today. We need to improve that situation. Yes?
We all, I'm one of them, believe that these systems provide better health care. Is there any evidence out there to indicate that you do get better patient outcomes? I haven't heard of any. I didn't say I...
There is. The question was, is there evidence showing that these systems provide better outcomes? Let me clarify. So the answer is yes, but there's an asterisk here. An electronic system is necessary but not sufficient for these outcomes. So these three issues that I mentioned, the technology, the implementation, and the people are necessary to get good outcomes. And yes, we've shown that we're reducing adverse events. We are improving adherence to preventive care guidelines and to other guidelines and best practices. This has been shown in a number of different settings, and increasingly is being shown not just in the hospital, but also in the ambulatory setting. But there's also evidence to show that it doesn't make a hoot of a difference. But if you look at those studies, it has to do with a failure of one of these three issues. Not implemented well, bad technology, or people that aren't using it. So I could have the greatest system in the world, but if I'm just using it as a word processor, I'm not getting any value out of that.
Haynes' work in this regard basically points out that the main improvements really are in process as opposed to outcomes. There's relatively little evidence of improvement and a reduction in mortality or improvement in morbidity. There is the issue that you get better guideline adherence, you get better, even more efficient processes and so on. But there's very, very little evidence, the way he registers ambiguous evidence, that you actually get clinical outcome improvements. So we're very interested in seeing, for example, meta-analyses that show that.
Yeah, I think that often when I'm saying outcomes, I'm really talking about intermediate outcomes.
Yeah, exactly.
So I don't think we have the long-term studies. Yeah. We haven't funded those kind of studies to show actually the long-term clinical outcomes. So we're depending on these proxy measures. Was the blood test done? Did the test get ordered? Whatever it is. We're looking at shorter-term things because we don't have the kind of huge studies that we have for, cardiology interventions, for example.
Yeah, it's an interesting problem, and I really push that, and that I think we have, as a community in health informatics, a major problem in proving that what we're purveying actually does make a difference beyond just the processes, but on actual outcomes. But you're right, it's a major problem. I want to ask a different kind of question. I want to make a point that related to what you said about keeping people happy. I was just experiencing an event, I think I told you about this, with the Conference Board of Canada. They've been engaged by the Ministry of Health to pull people together with the belief that somehow technology can improve the number of patients that can be seen in a practice. This is really what they're about. They called it improving the productivity of physicians. And the physicians who were there says, this is silly. I may want to spend more time with patients and see fewer patients. But seeing is the issue. We came to the conclusion in one of our groups was that the idea that you could keep many patients out there very happy with your email and communications and sharing of information without actually having to improve the volume that goes through the office, it's a very different idea. I wonder if you could talk a little bit about that. I know we had that discussion.
Yeah, we're very focused in healthcare on paying for things that happen in the office or in the hospital. And yet, particularly using technology, there's so much that we can do at a distance. We need to focus on healthcare, again, holistically, about providing healthcare through any channels necessary. I didn't mention this in my story about Dave, but Dave lives 3 hours away from Boston, where I practice. And yet I was taking care of him. Now, clearly, when he got chemo, he had to come in. But there was a heck of a lot we could do providing care at a distance. And I think we haven't even scraped the surface because I'm only using email right now or secure communications. But I'm not using video or any other technologies. If we change the way we think about healthcare and we think about outcomes, that we think about having good things, making good things happen, taking good care of our patient population, then we can free ourselves by thinking about this very inefficient office visit. It's increasingly ridiculous to think about working just in the office because you have to coordinate your schedule with mine, and we have to find that precious 10 minutes of time that we can share together in a single room. It's just bizarre. Why should we do that? Because there may be people who need to be here, but if we can take care of you at a distance, that would be so much the better. Some people need to be here, some people don't. And so I think that we just need to, again, change the way we think about this, and it's going to improve. If we change the way we finance healthcare, that's going to really help. We need to take advantage of technology and think about the big picture rather than focus on nickel and diming for these office visits.
Interesting. Do you have another question, or is one in the back here? Do you have another one? I do. Go ahead. And I'll do it.
A couple of years ago, talking to somebody about the issue of the electronic medical record, and it'd show up that you'd had this test, but you were with a different doctor now or whatever. That probably that doctor would order the test again because of the litigiousness, of our society. In other words, I don't want to be sued.
That's another commonality we have in the U.S., by the way.
Yeah. I don't want to be sued, therefore I better make damn sure this test comes out is appropriate. Just wonder what your comment there. In other words, duplication when there really shouldn't be, but because of the nature of society, it happens.
The question had to do with doctors reordering tests unnecessarily because they don't have the results from that previous test that may have been done by a different doctor a couple of months ago. This is one of the areas in which whoever's paying for health care benefits from a connected healthcare environment. We don't have that yet let's say it differently. We have it in very few places in the United States where we have a full community connectivity, a local health information network, to use your terminology here. We don't have that in very many places in the U.S., but that's what you need in order to make that happen. So within our very large network of physicians at Beth Israel Deaconess and Care Group, actually, is a larger organization, I can find out about any test that was done. But beyond that, if you were just down the block at another organization, I'm not going to know about those results. And the only way I'm going to know about those results is if I can find a paper record or if we have this connectivity amongst institutions. And one of our biggest barriers there is that we're in competition with other healthcare organizations. We don't really want to share information, and neither do they. So this is a tremendous challenge that we're facing in the U.S. I'm guessing it's going to be less of an issue here, but there are huge. So that's a business barrier. There are technology barriers as well to make that happen. But that's what you really need, and that's what's really going to eliminate the needless duplication of tests. I can't make the attorneys go away with all of this, though.
I'm curious about some of the disadvantages from a patient's perspective and from a physician's perspective. It struck me that Dave wouldn't be able to make an appointment to have his rotator cuff sorted out except with somebody who was wired. And you, in referring Dave and being able to refer Dave to that person, there might be restrictions on if the best orthopod is not within the group that you can get to in a wide way, in an intelligent way, that might affect how you practice. So both of those things sort of affect where Dave goes to electronically and where you might refer Dave to electronically. Is that a disadvantage? Is it an overwhelming problem?
So I'm not sure I understand the question. Is the issue that if I only refer Dave to specialists who use the technology, they might not necessarily be the best specialists?
And the best specialist that Dave could find on the web might also not be the best specialist.
Absolutely right. So you're onto something here, and I think this is a very important issue. One of the things that's been my observation is that there are really great specialists across all fields who really gravitate to this technology. Not to say there's a perfect overlap, but within the universe of really good orthopedists or really good oncologists, there is a subset who really believe and internalize this notion of information symmetry and engaging the patient. Does there have to be more of that? Yes. And hopefully we'll get there as we talked about before. But absolutely, this is an issue. And the other issue, frankly, because we don't have the kind of connectivity that you were asking about amongst the community, I wanted to refer Dave to somebody within our connected community, right? And so it's important that I have good specialists available within my connected community. If I did not, then that would not have been a good situation. So Dave's advantage was that he came to a doctor who is part of a connected community that has a great diversity of specialists and a lot of expertise. Other questions?
I have two, if there are no others. Second last one. You've gone into what's usually called the dark side, corporate America, and you've told us what you do for the corporation. What value has it been for you to be involved in Cisco, for example, your current one? What do you get out of it? I understand we get a medical school and health informatics and academia. What are you getting out of that environment?
Well, Dominic, I didn't know you were going to ask such personal questions here in front of everybody on the web. No, just seriously. First of all, one thing that I've learned is that the dark side is not so dark, first of all. And that's not a rationalization. Let me explain what I mean by that. And this is advice probably to any of you who are in academia who are considering this kind of a move. There is the good side and the dark side in academia as well as in industry. I have known many people to be in academic environments that are really quite toxic, really a lot of backstabbing, and are really very bad environments. And I've known people in the corporate world to be in similarly toxic environments. So I think that from my perspective, you've got to choose your environment carefully, whether it's an academic environment or a commercial environment.
Choose your toxic substance, right?
Yeah, exactly. I think that you must choose your environment carefully, whether it's academia. I think the difference between the two is that in general, in a not-for-profit world, you can be mission-driven, and you don't have to be profit-driven. And in the for-profit world, particularly a public company, whoever owns the company, the shareholders or whatever, that's what ultimately drives you. But on the academic side, there are many, or on the not-for-profit side, let's say, there are many not-for-profit organizations who are very worried about that money. And let's face it, no money, no mission, right? So it becomes a real preoccupation there as well. And on the for-profit side, there are many organizations that, yes, they're for-profit, but they do the right thing anyhow. And so I like working with companies that do the right thing anyhow, and let me do the right thing anyhow, even if it doesn't directly translate into money. So, yeah, I want this company to do very well. That would be important to me. I'm a shareholder, right? But at the same time, I want a company, and Cisco does that really has its heart in the right place and really does the right things for the right reasons.
So what do you get out of it? That's part of your fulfillment then? You're seeing your work going beyond?
What I get out of it is two things, Dominic. One is Cisco is a platform from which I can reach more people than I could do when I was at a single healthcare organization in the U.S. I'm traveling around the world, meeting with lots of interesting people, and having a larger impact. Another thing that I get out of it is just a personal development, personal growth. I wanted to be able to grow and learn new skills and try new things, which is why I changed. I wanted to go into a non-academic environment and see what it was like. So it's really those two things. It's a wonderful platform, working with a tremendous group of people around the world. I have colleagues all over. It's a great organization. But also it's giving me new skills, which I think are going to be useful to me in the future.
Interesting. For a while there, you looked like Fiddler on the Roof on one hand, on the other hand, on the other hand. My final question is, will you teach me how to dance?
Sure, come on over here. I'm leading, buddy. All right.
Thank you.
So we done?
We're done.
All right. Thank you very much, everybody, and we'll see you in cyberspace.
All right. Well, what a great talk and discussion. I really enjoyed every minute of it. Thank you, Danny, so much for making the trip from Boston and coming to give us your expertise and where you're traveling to in terms of the vision of this type of health care. I'm a believer. I'd really like to be able to engage as a patient with my doctor in this environment, so hopefully it will come to Canada soon. Anyway, on behalf of the Institute and the University of Waterloo, please accept this as a token of our appreciation. And to the audience, thank you for participating with us both here and on the web and by video conference. I hope you're enjoying the series. We'll take a summer break, as I indicated, and look forward to seeing you again in the fall. So have a great summer. Thanks a lot.